Welcome back to the channel, guys. We discuss the today a DEXA-ARDS trial, Dexamethasone treatment for the acute respiratory distress syndrome. My name is Dr. Buddha Bhushan Borade. You can follow me on Instagram, MediTalk by Dr. Bhushan, and you can subscribe to my channel, MediTalk by Dr. Bhushan, as the same name.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of some whatever. Under any circumstances, the author accept no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question for this study. In this patient with a moderate to severe ARDS, does dexamethasone in addition to routine care compared with the routine care alone increase the ventilator free days up to 28 days? Background for this study: ARDS is acute diffuse inflammatory lung injury response to the acute pulmonary and systemic insult. There are no proven pharmacological therapies for ARDS. There is interest in the potential use of steroid for ARDS due to their anti-inflammatory and anti-fibrotic properties. Different regimens of corticosteroids have been tested in ARDS with an inclusive result. The meta-analysis of 9 trials, number of patients 816, reported that steroid for ARDS reduced the time of extubation and mortality. The Cochrane review of 17 RCT, number of patients 2264, reported that steroid for severe pneumonia reduced the mortality. Trial published following the publication of this trial have demonstrated the reduced mortality in a patient with COVID-19 who are treated with a steroid. Design for this study: this is a randomized controlled trial, balanced treatment assignment stratified by the center in blocks of 10, use of opaque seal envelope to ensure allocation consignment, computer generated random table, treating clinicians were not blinded to study group, outcome assessor were masked to the study group, intention to treat analysis, sample size of 340 patients, give 80% power with a 5% false positive rate, detect the reduction 9 to 7 ventilator free days, 15% reduction in 60-day mortality from the baseline of 48. Trials stop early following the recommendation of data and safety monitoring board due to low enrollment numbers. Register on clinical trials government. This trials register on government clinicaltrials.gov. Setting for this study is a 17 intensive care unit in teaching hospital in Spain. Data collected during the March 2013 to December 2018. Population for this study: this is inclusion criteria: age more than 18, intubated and mechanical ventilated patient, acute onset of ARDS as defined by the American European Consensus Conference criteria for ARDS or by the Berlin criteria as a moderate severe ARDS. Within 1 week of initiating clinical condition: pneumonia, aspiration, inhalation injury, sepsis, trauma, pancreatitis, new worsening respiratory symptoms, bilateral pulmonary infiltrate on chest X-ray or CT, no clinical signs of left heart failure or absence of left atrial hypertension, pulmonary capillary wedge pressure more less than 18, PaO2 Fi2 ratio less than 200 mmHg, PEEP of 5 cm of water or more, PaO Fi2 ratio less than 200 at a 24 hours after the ARDS onset. First met moderate to severe ARDS criteria using the standardized ventilator setting. PEEP of more than 10 or Fi2 less than 0.5 are exclusion criteria: pregnancy, active lactation, brain death, terminal stage disease, DNR, treatment with corticosteroid and immunosuppressive drugs, severe COPD or congestive heart failure. 277 patient was randomized. Comparing baseline characteristics and of a dexamethasone versus control group: age 56 versus 58, female 31 versus 31, SOPA score 8.7 versus 8.6, time from intubation to randomization 2.1 versus 2.1, cause of ARDS pneumonia, sepsis, aspiration, trauma, degree of lung severity moderate, severe and mean, tidal volume, Fi2, PEEP. Comparing treatment received by intervention versus control group: receive continuous infusion of neuromuscular block agent in recruitment manner during the first 10 days of ARDS, 58 versus 59, prone ventilation 20 versus 30, ECMO 3.6 versus 6.5. Intervention: dexamethasone plus conventional treatment. First dose received immediately after being randomized and no later than 30 hours after ARDS. 20 mg once daily IV from day 1 to day 5. 10 mg once daily IV from day 6 to day 10. Treatment continue until the day 10 until extubated before day 10. Control: conventional treatment. Management common to both groups. Supportive management was not strictly controlled by the staff, were asked to follow standard guidelines. Outcome from this study: the primary outcome, number of ventilator free days significantly greater in dexamethasone group, 12 versus 7.5 standard deviation, difference 4.8 days. Standard secondary outcome, significantly reduced in dexamethasone group, all cause mortality at day 60 at 21 versus 36, and ICU mortality 19 versus 31. Duration of mechanical ventilation ICU survival 14 versus 19. The SOPA score from day 3 6.6 to 8. Significantly greater in dexamethasone group, PF ratio at a 6 days 219 versus 192. No significant difference in adverse events, complication, hyperglycemia in ICU, new infection in ICU, barotrauma, extubation failure. Post-hack analysis: number of ICU death from the multiple system organ failure significantly reducing dexamethasone group, 9 versus 17. Strength for this ICU trial: randomized control trial, multi-center blinding outcome assessor, intention to train analysis, use of two-step inclusion criteria with patient with recruited after 24 hours of standard ventilation. This means that the intervention was limited to patients who would be likely to benefit from this treatment. Weaknesses: low level of proning, no mandate to protocol for this use. Set a single country may limit the external validity. Each site had only recruited average 3 patients per year. Potential for selection bias. Trial stopped early due to the low recruitment. Treating clinician not blinded. Author conclusion: the early administration of dexamethasone could reduce the duration of mechanical ventilation. Overall mortality in patients with established moderate to severe ARDS. In patients with early but established moderate severe ARDS, the use of dexamethasone in addition to standard care significantly increased the number of ventilator-free days, significantly reduced the mortality. The majority of the patients were not prone. It is therefore unclear if its benefit remains in a patient who are treated with a proning. Thank you guys. Please like, share, comment and subscribe to my channel.